Okay, it is 2 minutes after the hour, and we're going to go ahead and begin the conference. My name is Terry Bauer. I am CEO of Specialdocs Consultants. We are delighted to have all of you join us this evening, and we're honored to have Dr. Paul Sachs as our special guest. Many of you have already read Paul's background, but I'll give a brief review of that. Paul is a clinical director of the Division of Infectious Diseases at Brigham and Women's Hospital in Boston, and he holds the Bruce and Robert Beal Distinguished Chair Award, and he's also professor of medicine at Harvard Medical School. He received his medical degree from Harvard Medical School and did his residency at BWH and then a fellowship in infectious disease at Mass General. For those of you who have joined us this evening, thank you for taking time out of your very busy schedules. We're delighted to have you with us this evening. Paul's going to go through a presentation for approximately 30 minutes, and then we're going to go ahead and have open question and answer. Many of you did submit questions to us. Thank you for that. We received over 5 pages of questions from the audience, and we're going to do our best to answer those questions during the presentation. If by chance we don't get to your question, please do speak with your physician that you see on a regular basis, because they're all very well informed, all very smart, and many of them are on this event this evening. So Paul, again, thank you for spending time with us tonight, and we'll turn the presentation over to you.
I want to thank Dr. Bauer for inviting me. It's an honor to be speaking about this to such a large group and such a diverse group. And I understand there are both physicians, nurses, and other clinicians on, as well as patients. This is targeted predominantly to the physicians, but I will explain what it means in real English as well as medical English. I am assuming you can see my screen, or otherwise you would say otherwise, correct?
Yes.
Okay, great. So I don't have any disclosures except for the fact that keeping up with COVID is enormously difficult. And I think this perhaps gives us the best analogy. The information changes constantly. And in fact, when Terry first contacted me about giving this talk, we tried to plan it ahead of time, but it was impossible because actually it was before the arrival of Omicron. So let's start with a discussion of epidemiology. This is something that undoubtedly all of you know. There has been a huge increase in case numbers. All of you, all of us know more people, more patients, more friends, more family, more colleagues with COVID-19 during this surge than we did at any point in the course of the pandemic. And it's not even close, and that's shown in this data. Remember, of course, these are underestimates because these do not include either home tests, nor do they include very mild cases where people choose not to be tested at all. Now, this is mirrored in the Europe. Europe always provides this little signal of what we're going to get next. Often it's the United Kingdom, and then it first appears in the East Coast. You'll notice here that there's one important difference, and that is that there is now a decline in cases in the United Kingdom that's rather sharp. And this indicates that in general, these particular Omicron-based surges are short-lived, which is a very good thing, if you ask me. So one thing that we have in Boston is monitoring of the wastewater for concentrations of SARS-CoV-2, which is the virus that causes COVID. And you'll see that this is the amount during last winter, which was what we thought was a very bad situation with COVID. And now with Omicron, we've greatly surpassed that by hundreds of fold. And yet again, we're seeing, after a peak that occurred in very early January, a sharp decline, which is, again, cautiously optimistic. So that is the issue with the epidemiology. Let me now shift to discuss Omicron, because that is the current variant of greatest interest. So it's a Greek letter of the alphabet that I actually didn't know before this, having only Spanish language ability and not Greek. It is, even its pronunciation I didn't know, and Omicron is how most people say it now. And the reason it's different is because of two three factors that I will discuss. One is that it evades your previous immunity, your antibody immunity, whether it's vaccine immunity or whether it's prior infection immunity or both. It appears to be more transmissible. And fortunately, it does appear to be less severe. And I show this curve here because this is the number of students diagnosed with COVID-19 before and after the arrival of the Omicron variant at Cornell University in New York. And this kind of epidemic explosion is what's been seen in every single region. So it's quite different from our ancestral strains of this virus. It has more mutations in what is known as the spike region, which is the outer part of the virus through which it communicates with our immune system. Some of our tests have what's known as a spike gene target failure. That doesn't make the PCRs negative, but it possibly may lower the accuracy of our antigen tests. There are mixed data on that. But as I alluded to, it has a lot of implications for reinfection, vaccine effectiveness, and monoclonal antibody therapy. In South Africa, where this variant was first described, the reinfections were 2 times higher than previously, and then breakthrough cases were also more common. They are partially protected by a 3rd vaccine dose. And if you're wondering what should me and my patients do who've had 2 COVID vaccine doses, get them out for their 3rd dose as soon as you can. This can be the period could be shortened, in my opinion, to as little as 4 months after the 2nd dose. But right now in official guidelines, it's 5 months. There is some concern about the J&J vaccine. In fact, J&J vaccine overall appears to be less effective in almost all modalities. And I would suggest that people who got the J&J vaccine actually get a full mRNA series with either the Pfizer or the Moderna vaccine. So what about monoclonal antibodies? Well, one way we measure how effective monoclonal antibodies is we do something called fold change. And the way you define what fold change means, it's the amount more resistant than a non-resistant virus. And if you look at these various monoclonal antibodies, which have these long names, they're often known better by the companies, you'll see that the fold change of all of these is either not applicable because they can't neutralize it at all, or it's increased. So this is Sotrovimab is the only remaining monoclonal antibody with proven activity against Omicron with a fold change of 2.8. And 2.8 is only just under 3 times resistant compared to previous variants. And Sotrovimab concentrations can be achieved. But what this means is that previously available therapies to you are actually not available now. So for example, the Regeneron compound might be available to you, but it's not going to work against Omicron. Moving on now to transmissibility. Every place this variant has entered, it has had steep growth curves that I've showed you. Household transmission, just a reminder to everybody that even within households, even with this more transmissible variant, household transmission is not 100%. Everybody knows people who've lived in a house with someone with COVID and they didn't get it. And they say, how did that happen? Well, it's about 30 to 40%, but that is still higher than previous strains. The other thing that's been reported is super spreader events among vaccinated people, most famously at a party, a holiday party in Norway, where something like 80% of the people who attended came down with COVID. Fortunately, most of them very mild. There was one case report about someone in an isolation hotel in Hong Kong who transmitted it to the person across the hall. And all the person across the hall did was open his door to get his room service. However, as I mentioned, that doesn't mean that these household transmissions are universal. They still worth having precautions. Now, there is this observation that the growth of the virus is faster in the bronchus cells, which these are the bronchus, the cells in the upper airway, but they're not growing as well in the lungs. And if it's true that the virus doesn't grow as well in the lungs, this may partially account for why it's less severe, a less severe infection in the lungs, because it's actually it's not causing where severe cases occur. And this has now been reproduced in 7 different studies, which is actually excellent news. So What about clinical severity? These are data from South Africa. You have the Delta wave here, which occurred in the summer in South Africa, and this is the share of patients in intensive care. These are share of patients on a ventilator. This is the Omicron wave. You can see the percentages are way, way lower. And that has been recapitulated in Europe. I show you data here for Portugal. Portugal is a very heavily vaccinated country. These are the numbers in the last winter, big increases in cases, big increases in deaths. Notice an even bigger increase in cases more recently, and yet deaths have been relatively flat. So cautionary optimism that this really is less severe. This is data from New York City showing that vaccinated people are very, very unlikely to end up in the hospital. If your patients are wondering, why should I get vaccinated even though Omicron can break through the vaccines? Show them this figure. This is the reason right here. Vaccinated people are much less likely to get severely ill. So why are they less severely ill? I'll try to explain it using this figure. This is a PhD scientist in epidemiology, Natalie Dean. Here's a variant that can't cause much in the way of reinfection. And you see that some of them are severe, some of them are not severe. There are a bunch of people who are immune and don't get infected at all, so that's good. If you then take a look at Omicron, which can reinfect people, some of the mild cases are actually reinfections. And so a higher proportion of total cases are not severe. So it could be our immune response. So let's try to wrap it up. What does this all mean? What does this Omicron stuff mean? First, get vaccinated, get boosted. We can't rely on monoclonal antibody treatments. Sotrovimab is in short supply. The vaccines are still highly effective in preventing severe outcomes. Transmissibility. If you want to be very safe, improve the quality of your mask, stay out of close contact places with poor ventilation, use rapid testing, which, as you know, today you can sign up for your free rapid tests to reduce the risk of social gatherings. Those are all things we can do. The decreased severity is clear. Now, whether it's because of prior immunity or the virus is less pathogenic, it doesn't really matter. I'm going to take the optimist view and say it clearly is less severe. The clinicians on the phone, on the call, on the webinar right now, you know what I'm talking about. Most of the people you speak to with COVID this time have very mild illness. Not all, but most. This is still very disruptive, but it's better than it was before. Okay, now switch on to treatment. Let me talk about antiviral therapy first. This is a picture from a very famous scene in a movie. I'll tell you, nothing could explain better the importance of antiviral therapy and time. The key issue with antiviral therapy is getting it to patients as quickly as possible. It's absolutely critical, whether it's monoclonal antibodies, Remdesivir, which is mostly given in the inpatient setting now, Molnovir, or Novotrovir plus Ritonavir. I'll discuss each of these. Let's look at why time is so important. If you look along the horizontal axis, it's the time course for someone with COVID. This is the severity of illness. It starts out like a very mild illness, respiratory illness, and that's when the virus is reproducing like crazy. And that's when antiviral therapy works. Later on in the illness, during the hospitalization phase, the body's immune response is kicking in, and that's where we use things like dexamethasone and tocilizumab and other immune modulators. But at this point, out here, it's too late for the antiviral therapy really to do much. So if you're going to get antiviral therapy to our patients to help them the most, we have to get them to them fast. So let's talk about Sotrovimab. Sotrovimab is the lone monoclonal antibody I mentioned that still has activity against Omicron. You'll note that in this study, it had an 86% reduction in the risk of being hospitalized or dying. These are patients who had symptoms for 5 days or less, okay? Some of them, many of them had symptoms for fewer than 3 days. So that is a good thing to think about. Do not delay getting this treatment to people. Now, Sotrovimab is in short supply. And these are our local data. This is what happens when lots of people get COVID and there isn't that much Sotrovimab. All the yellow bars are more referrals for monoclonal antibodies than treatments. If you've had patients who've needed monoclonal antibodies and they didn't get it, this is the reason why. It's not available in sufficient supply, and also the logistics to give it are actually quite difficult. IV therapy in the outpatient setting, I need not tell experienced clinicians, is not an easy thing to arrange. So how can we make this better? Well, one way is getting rid of the need to give intravenous therapy. And sotrovimab's manufacturers have applied for an intramuscular administration. And so intramuscular administration, if it's as good as IV, and it looks like it's nearly as good, then we could potentially get this to be as kind of treatment you could administer in the home. You have a nursing service who heads out to a patient's home, they give an IM injection, observation, and done. Placing an IV is very much a rate limiting factor for a lot of these treatments. Speaking of IV therapy, there is an antiviral called Remdesivir that's been used on the inpatient side for over a year now. And we recently saw the results of a study of Remdesivir given to outpatients. Study results were actually downplayed because the company that makes Remdesivir didn't think it had much in the way of potential. So these are people in the outpatient setting, non-hospitalized, high risk for bad COVID outcomes. They get Remdesivir for 3 days or placebo. And the primary outcome is whether they need to be hospitalized or die of COVID-19. And these data are very impressive. Remdesivir given in the outpatient setting had a marked reduction in the likelihood of getting hospitalized or dying. 2 deaths in the Remdesivir group, 15 in the placebo group, highly statistically significant. It probably would have been even better, but the company decided to stop the study early because A, they thought the vaccines would make this immaterial, and B, they realized that 3 doses of an IV wasn't going to be able to compete against monoclonal antibodies, which are 1 dose. However, remember, there's only 1 monoclonal antibody that currently works, and we don't know how variants in the future are going to respond to monoclonal antibodies. I think the risk for resistance is high. So I do think that outpatient Remdesivir could fill the gap left by a shortage of monoclonal antibodies. If we can get it to people in time since symptom onset is the leading predictor of Remdesivir activity. People should not be hospitalized with COVID-19 and then observed until to see if they need Remdesivir. Remdesivir has to be given early. Anyone with symptoms should start as soon as possible. How do you do it? Well, there's almost no experience to date, except for recently over the past couple of weeks of giving Remdesivir in clinical practice, out in the outpatient practice, but we're starting. It's a very safe drug. We are trying to do it in our healthcare system. I'll say we're the place we've had actually the most success is in pregnant women who come to labor and delivery and receive a dose of Remdesivir, leave, come back the next day, get another dose, leave, come back, because they're used to giving intravenous therapies in labor and delivery. In the inpatient side, we're treating most of our patients now who have mild disease with 3 versus 5 days. Okay, the next drug to discuss is Molnovir. And the way this works is it actually induces RNA mutagenesis in the virus. And keep that in mind because there's potential consequences for the safety of this drug. There are 2 unsuccessful studies, one done in the United States and Europe and one done in India, did not work. But there was 1 study in which it had favorable results. I'll show you the results here. It was basically outpatients like the one in the Remdesivir study who had symptom onset in 5 days. They got 5 days or fewer, 5 days of Remdesivir of Molnupiravir twice a day. And then they had an interim analysis that showed a 48% reduction in hospitalization or death. And then the final analysis, 30% reduction, better than nothing. I think probably the primary reason that the FDA moved to approve this was this imbalance in deaths. There was 1 death in the Molnupiravir group and 9 deaths in the placebo group. So right now it's approved for these people, adults with mild to moderate COVID at high risk for progression. Important, not recommended during pregnancy. It may cause fetal harm. Individuals of childbearing potential should use contraception for 4 days. Remember, this is a mutagen, and a mutagen to give to people who may become pregnant is not a good idea. Males of reproductive potential who are sexually active with females should use contraception during treatment and for 3 or more months afterwards. Not the kind of news you want to hear. And we also see that this drug didn't work in the full analysis. In 2 other studies. Would it work in a vaccinated population at all? I think the safety is an open question. And then there's a group of virologists who actually think Molnupiravir's mechanism of action is going to stimulate the development of more variants. And that's not something we want. So this is one of those virologists. He's out at Stanford. He says, would you prefer we get back to normal sometime or we make new vaccine evading coronaviruses continuously? It's like a very concerning perspective. I think that giving someone Molnupiravir, the ideal patient would be an older patient, say someone in their 70s or 80s, obviously no reproductive issues, lots of drug interactions because this does not have drug interactions, but I'm not sure I'd even want it then. I think I would prefer Sotrovimab. The other antiviral that's orally available is Novotrovir, and it's given with Ritonavir, and it's given as 3 tablets twice daily. It's been studied in that same patient population. We've seen the results of 2 of the studies. This is the high-risk population, and it was a real winner. Patients got Novotrovir or matching placebos. This is called Paxlovid. They planned to enroll 3,000, but they stopped early. And why did they stop early? Because the Novotrovir substantially reduced the risk of hospitalization, 0.7% versus 6.5%. That's the kind of thing that Data Safety Monitoring Board stops a study for. No deaths versus 12. Especially effective in older patient populations, 94% reduction in study participants 65 or older. Reduced the amount of virus in people as well, potentially making them less contagious. And they had fewer side effects than placebo, always a good sign. It means the drug is making people feel better. They also did a study in people at low risk, and they either were low risk because they had no risk factors or they were vaccinated and had 1 risk factor. And they've analyzed 80% of the study subjects. There was a trend towards significant improvement. There was actually some clinical benefit, and there also was this viral load reduction. So what are the concerns with this drug? First, lots of drug interactions. We HIV and ID doctors are used to this in our HIV patients, but it's going to take some looking things up. GI side effects are common with Ritonavir. It's in very short supply now. And like all these antiviral therapies, you got to start early. Start early. So what about the drug interactions? These are not drug interactions that are for the faint of heart. So there are some things that are contraindicated that actually are used very commonly. Amiodarone, clopidogrel, rivaroxaban. We use a lot of rifampin in ID. Can't use any of these with this drug. I think that if you have a transplant patient, you can monitor their levels of their cyclosporin or tacrolimus. That's for your transplant docs. Some of these drugs we just hold for 5 days, or actually its recommendation is hold for 8 days. There are these 2 websites that have excellent drug interaction information. One of them is based at the University of Liverpool. So I put this picture of the Beatles there to remind you. So where are you going to find these drugs? Well, there is a website that has some access information, and it's a DHHS COVID-19 Therapeutics Locator. If you search that with Google, you'll find it. This is the Boston area. You could see that we have very few available Novotrovir courses right now. That's changing constantly. Keep in mind, this is going to change over the next several months. So to wrap this up, the treatments, 10 days, window to apply treatment, 10 days for Sotrovimab, 7 days for Remdesivir, 5 days for Paxlovid, 5 days for Molnupiravir. PO therapy, easier to administer, definitely preferred. I think that when supplies are out there that are sufficient, most people will be prescribed Paxlovid. A fraction will get Sotrovimab, and then a smaller fraction yet Molnupiravir, but that might be just so easy to give that people give it, but they really want to see more efficacy and safety data. So prevention. Now, some patients are immunocompromised and they cannot respond to vaccines, and they are interested in something called PrEP, or pre-exposure prophylaxis. And there is a monoclonal antibody that is tixagevimab, which is made by AstraZeneca and called Evusheld. It's been tested in a large population. I'm going to pause 1 minute.
You've been talking nonstop for 25 minutes. You deserve a little water. And folks, those who may have come on a little late, Dr. Paul Sachs is going to continue through about 35 minutes after the hour, and then we're going to open it up to questions. I will tell you that we did receive over 5 pages worth of questions. So those of you who put questions in the chat, will try and get to you, but I think it's going to be a little bit of a challenge. Also, for those of you who may have missed the beginning of the presentation, it is being recorded and it will be available on our website. You will get an email so you can, probably from your physician, so you can be forwarded to that link. Paul, doing better?
Water.
Great, thank you.
All right, so this is a prevention study. And the data speak for themselves. These are high-risk people, but a lot of them were at high risk for bad COVID, but not high risk because they were immunocompromised. Keep that in mind. But you see that giving this every 6 months to this population, incidence very, very, very low in the treated patients, but also pretty low in the other people. So this was significant, but very low incidence, period. And the other thing that is of some concern is, remember that fold change table. Omicron is partially resistant to this monoclonal antibody combination. Now, the makers of this combination, AstraZeneca, have a press release that says it's still active. The data are actually kind of fuzzy. So I am not sure whether this is going to work or not. And I'm especially not sure because the people who are getting this are the highest risk population. So patients who are severely immunocompromised are the only people getting this treatment right now. So the kind of people, for example, who are taking B-cell depleting therapy, that means something like rituximab or a Bruton's tyrosine kinase inhibitor like ibrutinib, or have a transplant. These are very high-risk people for vaccine non-responses. They're currently getting this treatment to prevent COVID. Whether it works in this population or not is unclear. I am recommending it, but I have to say I am hopeful that sotrovimab will actually be able to show something similar because it's more active against Omicron. The last thing I'm going to talk about are repurposed drugs that anyone can prescribe even now. And let me start by talking about fluvoxamine. Now, fluvoxamine is an SSRI that activates the sigma-1 receptor. That's not what it was approved to do. That's an off-target effect. It's an antidepressant. It's used to treat obsessive-compulsive disorder, but it was found in animal models to reduce inflammation. And they've now studied it in 2 randomized clinical trials in COVID. And the results look favorable. In this study, this is fluvoxamine, likelihood of needing hospitalization, 0.68, and the effect was stronger in the per protocol analysis. So people who took all the doses that were recommended ended up having a reduction of about 70%. Also, fewer deaths, and the results were consistent across subgroups. I'll just show you a subgroup analysis. All the point estimates line up to show that fluvoxamine is better. So fluvoxamine is something that, as I said, you can prescribe now for treatment of COVID-19. It is not in national guidelines, but some people are recommending it. If you look at things more graphically, this just shows the fluvoxamine being better in this likelihood here versus the placebo group. There's a 98.9% chance from this clinical trial that fluvoxamine is better than placebo. That's pretty good. So to summarize, 2 randomized trials suggest benefit, still is being studied in clinical trials. In fact, your patients can enroll in these studies without your referral. They'll just mail them the medicine and they can help, improve research. Some local guidelines do include it. I cite Washington University in St. Louis. They say in their guidelines, fluvoxamine may be considered for high-risk patients who cannot get monoclonal antibodies or other antiviral therapy. And I have to say that the University of Waterloo in Toronto, they are all after fluvoxamine. They were collaborators with the people in Brazil who did the study. They have a really good guide for how to prescribe this. People in primary care are used to prescribing SSRIs. You know about the issues. And then the last thing I want to mention about fluvoxamine is that it's got a bunch of drug interactions, but the one that would probably come up the most is caffeine. It markedly increases caffeine exposures, so that people who take fluvoxamine definitely should cut back on their caffeinated beverages. And then the very last thing I want to discuss is inhaled steroids. If you look at this study of ciclesonide versus placebo and this Kaplan-Meier curve, you would say maybe ciclesonide doesn't work so well. And this was actually the primary endpoint was resolution of symptoms. But when you look at a secondary endpoint, which was need to go to the emergency room, ciclesonide clearly had some effect. And this is not the first time we've seen this with inhaled steroids. A budesonide study also showed the same thing. So if you have a patient with COVID-19 and they have, particularly if they have pulmonary symptoms, a use of inhaled corticosteroids is very justified based on these data. And I put the doses of ciclesonide and budesonide that you could use. So let me wrap up with just sort of my personal preference for these treatments. If it's available to you, Novotrovir, Ritonavir, or Paxlovid is, I think, the best option. It's oral. It has an 80 to 90% reduction in needing to go to the hospital or death. The data look very good, at least the data we've seen so far. Sotrovimab is very effective, but it's hard to give, and I think the IM administration will be better. Remdesivir as an outpatient, I just want to put this here because it does work. It's just hard to do, and there is a Remdesivir oral formulation in development. I've expressed my concerns about Molnovir, and then it's sort of parenthetically, I think that these treatments, fluvoxamine and ciclesonide, are kind of forgotten in part because they do not have, a big pharmaceutical company push behind them. They're really kind of been found by investigators. They're very inexpensive. They're both generic. They might actually have a really good role. And so let me stop my share right now. I am happy to take questions. I mostly covered treatment, but I'm happy to take questions on anything related to COVID-19. Thanks so much.
Paul, thank you very much. Very informative. And I wanted to start with some of the questions that were submitted by special docs, physicians. The first one is, I've read that asymptomatic vaccinated people may harbor as much virus as asymptomatic unvaccinated people. What is the risk of an asymptomatic unvaccinated person infecting an asymptomatic vaccinated person?
Unvaccinated asymptomatic person infecting?
Asymptomatic vaccinated people, I'm sorry, what is the risk of an asymptomatic unvaccinated person infecting an asymptomatic vaccinated person?
So the likelihood an asymptomatic person has COVID at that moment depends a lot on the local epidemiology, the case incidence, and what sort of behaviors have that person been doing. So someone who is asymptomatic person who goes to lots of bars, crowded bars and restaurants during the Omicron surge, there could easily be a 1 in 10 chance, 2 in 10 chance that person harbors COVID at that moment. But a person who's basically not doing any of those things, it's very unlikely. And it's exactly in these settings that the rapid home tests are useful for socializing, because you could take an asymptomatic person, do a rapid test, and that takes a low likelihood situation even into a lower likelihood situation. It's all part of Bayesian epidemiology, prior probability. So I don't know if that answers the question, but it is actually how I think about the asymptomatic transmission risk phenomenon.
Very good. Next question is, do you believe that these highly contagious but less virulent variants signal the end of the pandemic through herd immunity?
That's a view that is being held by some, and I think there is some, justification that we're heading in that direction. you saw those case numbers, and I already mentioned that is a wild underestimate because of both home testing and mild cases not being not mild cases don't get tested at all. So I've heard estimates 3 to 10 times more people have gotten COVID than actually have been counted in this last round, and that some people estimate that as many as 50 or 60% of all of Europe will get COVID in this surge. So the plus side, it boosts your native immunity. There is a contrary view that is, I have to just acknowledge that it exists because it's out there. Some people say the reason why other coronaviruses are so benign is because we grew up exposed to them and we developed, our immune systems learn to tolerate respiratory viruses over time, and that it's therefore going to take some time, and we may never be able to learn how to do that as adults. So somewhere between those two views is probably closer to the truth. We're clearly in a different place than we were last year. The disease is milder now in aggregate, despite the fact that in some people it's still severe.
The next question is somewhat related. Any input on whether children under 5 will be approved to get vaccines soon?
So the studies of vaccines in young children have been slowed by difficulty finding the most effective dose and dosing scheme. The first round of dosing did not induce the kind of immune responses that people were hopeful for. And so as a result, the studies were slowed. I do think we'll see favorable results in the under 5 population sometime in this calendar year, which I know just started, so it doesn't sound so great, but I do think that we'll get there. One of the silver linings of having lots of cases is that you get to have a faster signal on your vaccine efficacy studies.
Next question. Thoughts about the value of a 4th booster for age 60 plus. I know there was a study that was released from Israel today.
Yeah.
Or yesterday.
It's very, right now, when you look at that study, you go, there's no point in giving a 4th dose. But they gave it within 4 months of their 3rd dose. So in some ways, it's not surprising it didn't show any benefit, right? Because people who get boosted, their antibody levels are already very high. And that 4th dose, I don't know that it would do anything. However, a 4th dose a year from dose number 3, or a 4th dose at some point in the future is plausible. And what the hope is that they are able to find a conserved antigen in the virus that doesn't need constant tweaking, so that we don't be in the situation of continuing to see variants that break through our immune defenses. So that's the hope, that there's a coronavirus, a SARS-CoV-2 antigen that's conserved, that it will not change with future variants sufficiently in order to make protection more durable.
Next question. Is an Omicron vaccine going to be available? And if so, is it needed? And if it's needed, when might you anticipate it would be available?
So the issue is those epidemiologic curves that I showed you, where it comes into a community and takes off, and then it leaves almost as fast as it arrived. Do we actually need an Omicron variant vaccine? I think one could make the argument that we don't. It would have been nice to have it 3 weeks ago, but that isn't like something you can just do. So it takes, even though mRNA vaccines are quite adaptable, they're not going to be adaptable like that. I mean, with each variant that comes in, there's been discussion, should the pharmaceutical companies make a variant-specific vaccine? And, the vaccines, they're still, a fully boosted immunocompetent person is over 90% reduced risk of even hospitalization and 99% reduced risk of dying. That's amazing. So they're still doing something.
Yes, it's a strong reason to be vaccinated twice and boosted.
Yes.
What's your perspective on long COVID and other long-term effects of this infection?
It's quite real. I think I've seen really two forms of it. One are people who have really terrible objective changes to their bodies, their brains, their lungs, their vital signs. They're tachycardic all the time. They're short of breath with minimal exertion. They've clearly been damaged and scarred by their COVID. Another group has nothing that I can find like that, but they're just not the same. Their brain isn't the same. They tell you they're tired all the time. They have brain fog. They have a lot of the same conditions that people who had severe Lyme disease get in New England, where they have a lot of nonspecific brain fog that never goes away even after Lyme has been treated and eradicated. So I think those are the two big groups. There's some overlap, of course. That first group is I actually see them and then refer them to pulmonologists and cardiologists because there's definitely some residual scarring from their initial infection. The second group, I think, a neurobehavioral assessment because they cannot seem to concentrate. They can't focus on things as well. They are tired with minimal mental effort and physical effort. It's very much reminiscent of a lot of the post-infectious fatigue syndromes that ID doctors have seen for their whole career, like me.
Next question. Many people get COVID more than once. When counseling unvaccinated patients who have had COVID once or twice about getting vaccinated, is there any data to give them about the chances of subsequently developing serious illness?
Yeah, there's definitely data. And it's, I think one way to explain it is that even though getting COVID has reduced your risk of getting it again, it doesn't eliminate the risk. And we can't predict who the people are who remain susceptible either to getting COVID again or getting severe COVID again. And I often cite a published case report because it's so dramatic. It's a physician who had COVID in Spain in the first wave, like March of 2020. And then in the summer of 2020, after complete recovery, he got severe COVID, ICU level COVID. And because he was at an academic medical center, they had access to all of his viral and immune measurements and were able to find it was a totally new virus. It was not like persistent infection, that his immune response from the first event had completely worn off by the second event, and that he suffered a great deal. He actually required ICU care. So, I mean, it's not, when I give you a case report like that, obviously it's not common, but it's not unheard of by a long shot. So the great thing is that getting vaccinated on top of having had COVID before gives people the most protection from severe outcomes and reinfection. So those are the people who have the best protection. It's the broadest immune response. They've had the virus and they've had their vaccines. And there was just a study out of the Cleveland Clinic that shows that even in the Omicron era, I can't believe they're able to publish the study so quickly. People who had vaccine plus booster were much less likely to get symptomatic or asymptomatic COVID-19. These are healthcare workers at the Cleveland Clinic. So it's worth it, even much more than people with previous COVID.
Moving on to a question about tests. Some package inserts for home COVID tests get a single accuracy number, which seems odd. The positive predictive values and negative predictive values are independent and depend on the prevalence in the community.
Agree.
Can you help explain that, a single number, and also comment on the data you are aware of and changes in accuracy with Omicron?
Yeah. So first, your first comment is absolutely correct. Positive and negative predictive value are not entirely, but are extremely dependent on the prevalence and the incidence of infection in the community. And in a high risk time, especially if someone's symptomatic and their rapid antigen test is negative, the negative predictive value is very poor in that setting. By contrast, in a lower risk time, in an asymptomatic person, a negative predictive value of that same test is extremely high. Now, as for the questions about Omicron and antigen tests, there's been a lot of studies. The study data are conflicting. Some of the studies show that the most popular rapid test in the United States, the Binax Now, works just fine for Omicron, and other studies that show that the sensitivity is significantly reduced. I think one way to look at it is if you have symptoms in the current era with Omicron and your test is positive, you're done. You don't need to do any further testing, no PCR, nothing. But if you have symptoms and your test is negative, you have to do another test, either 24 hours later, or a PCR, because it's not good enough to just say a negative antigen test. We've known that all along. The other thing is that asymptomatic people with a negative antigen test can be pretty reassured that their negative test is correct. The only exception would be people who've had a very high risk exposure in the days preceding that negative test. So I think the negative testing before social gatherings has been downplayed because it's not perfect, but it is much better than nothing.
Okay, great question, great answer. Initial reports were there was a trend towards higher mortality with using oral steroids prior to hospitalization. Is that still the case?
I strongly counsel against using steroids in the outpatient setting unless your patient is already on oxygen, which would be very uncommon. In the largest study of steroid use, which was done in all the inpatient units in Britain, they found that the people who got corticosteroids who didn't yet require oxygen actually had a trend towards increased mortality. So I hear about people in the outpatient setting being prescribed prednisone, azithromycin, ivermectin, vitamin D, hydroxychloroquine, is this cocktail, just throw it at them. Not a good idea. Not a good idea. I've basically told you the drugs for which I think drugs for which I think we have some data, and that's fluvoxamine, ciclesonide, and budesonide. And the rest of them, I don't think the vitamin D is harmful, but I would not use azithromycin, ivermectin, or hydroxychloroquine or corticosteroids in the outpatient setting.
Very good, thank you. I'm going to move on to some of the questions that came through with our patient members. Many people asked about natural immunity and herd immunity. You talked about it a bit, but can you expand upon that for us?
So I'll just say we're not there yet. But if a sufficient number of people have a protective immune response against this virus, either through vaccination or prior infection or both, then this virus will recede and become like our other endemic respiratory viruses that have a periodic increase in the wintertime. We're all familiar with this. Hospitals have always gotten more crowded in the wintertime because of respiratory viruses, but will not cause the kind of mass disruption and devastation that we've seen over the past 2 years. So that's where we hope to be heading. I think, I'm the optimist by nature, that we're getting there with this latest round of a less severe COVID, which is Omicron. But I don't like to make firm predictions because people who make firm predictions about COVID have been wrong many, many times. And I just don't want to make that mistake. So
many people ask about what's safe to do now. People have been locked down for going on into our 3rd year. And what do you recommend in terms of staying safe? Vaccinations you've touched on, maybe talk about masks, talk about other things, just so people can have some sense of calm.
Well, a lot of it depends on who you are. I mean, if you're a otherwise healthy person, almost regardless of your age, and you've been fully vaccinated, we know how this is transmitted. So, you can safely gather with your family and see them indoors without masks, especially if they provide a negative test before gathering. I mean, that's what I do with my, you could tell from my gray hair, if I have parents, they're old. and I see my parents and I test before going to see them. So this is a choice we make. There's nothing is going to be zero risk, but you can make that risk as low as possible. If you're in a crowded setting that you can't control the environment, by all means, upgrade the mask. I think that one of the disservices our policies have done is they've said mask, but they don't even specify what kind. Fortunately, the CDC now has given you a hierarchy, and they should have said that cloth masks don't really do much, but they didn't. They still include them on the list. But I would say if you can get an N95 mask that you find comfortable and fits well, or a KN95 mask, that would be fine. And then also the surgical masks do work better than nothing. And surgical masks are very, very commonly used in the hospital setting, in the doctor's offices, and they provide some protection as well. As far as other things, ventilation is I never thought that as an infectious disease specialist, I would read so much about ventilation, but it turns out it's enormously important in prevention of respiratory viruses. And, we talk about safety of schools, safety of hospitals, safety of doctor's office, safety of every place would be greatly improved if we improve the air quality within our buildings. One of the discouraging things about some of the newer construction is that they eliminate the possibility to open the windows, which turns out to be a very low-tech way of making a gathering area safer. If you want to invest in some air filters, they do also appear to help. And I wouldn't say don't do it, but I just want to say that they sort of complement everything else. So is that helpful?
Yes, I think so.
Okay. And then I do think that ultimately we will have, for people who are immunocompromised, that monoclonal antibodies might find their niche in this population. I just am worried that the Evusheld, which is the AstraZeneca one that has this approval, may not be that effective for this purpose. I would say, yes, try to seek it out if you fall into that category, but I'm not that optimistic it's going to do much, but we'll see. I hope I'm wrong on that one.
Okay. A number of questions on over-the-counter things like quercetin, zinc, vitamin C, vitamin D. What's your perspective on people taking those?
Of all of those things, the one that has the best evidence is vitamin D.
Okay.
That said, the data from treatment studies of COVID with vitamin D they're not strong enough to make it a guidelines recommended intervention, but there have been randomized trials for prevention of respiratory infections, and vitamin D does appear to do something rather than nothing. I would not recommend vitamin C. I would not recommend zinc. Just caution about zinc. If you take too much zinc, you can actually get zinc toxicity, which is not pleasant. It's actually correlated with it can be directly toxic to olfactory cells, which are the cells involved in smelling, which is not a good thing in people who have COVID, believe me, as you know.
Okay. Last question here, because we're coming up on the top of the hour, is if a fully vaccinated boosted person has experienced a breakthrough case and has been asymptomatic, can he or she still be shedding virus particles during their course of isolation, 5 to 10 days? And will he benefit from increased antibody activity once he's come through this?
So the person who gets that breakthrough infection does generally have an augmentation of their immune response. So that's the good part. The other thing is that people who have mild cases, they often clear the virus faster. The CDC did not put a requirement for antigen testing for people to come out of isolation, but it does make sense. If you can do an antigen test at day 5 and it's negative, then you could feel much more comfortable about leaving isolation. If you could do one and it's still positive, then try one again 2 days later. If that's still positive, then give yourself 5 days off and try again. Most people who are immunocompetent will clear the virus by day 7. And most of the transmission happens within the first 3 days because the virus levels are the highest. So, right now it's basically been said, if you don't have tests, you can come out of isolation at day 5 and then wear a mask for another 5 days. That's not going to be perfect, but it's going to be better than nothing. And also it's going to allow people to get back to society.
Okay. Paul, you've answered so many of the questions that people posed. At the peak, there was over 1,000 people on this webinar. So we had quite an audience. You're a great draw. And we are very grateful to you for sharing some of your experience, your intelligence, and your wisdom. Also, I want to thank Brian Bilczyk for introducing us to one another. Thank you, Brian, assuming you're on tonight. And Paul, I'll give you the mic for any closing comments.
I just want to first thank you, Terry, for the invitation. I want to thank all of you for coming and showing interest in this. It is a humbling experience for all of us to be trying to get through this. It's hard, but the great news is that we've made a lot of progress. Things are already way better than they were last year, and last year was already better than they were at the beginning of 2020, where we were just all very terrified. So thank you for your questions.
Well, thank you again very much. And again, for those of you who attended this evening, if you missed part of it, there will be a recording. We'll figure out a way to get that information to you. Paul is also going to be gracious enough to share the deck he went through. I will caution you that this is a very rapidly evolving situation. As Paul said when we first started talking about this, we didn't know what was going to happen in January. I'm glad we did it at this point, Paul, than we did it back a month ago. So I think that was a fortunate move. But again, for those of you who participated, hopefully you come away a little bit smarter, maybe a bit more comfortable, and maybe better prepared to handle this. So with that, I will say good evening to everybody. Stay healthy, stay safe, stay well, and we will see you again next time.
Bye.
Good night.